everyone. Welcome to TEPI's Infection Prevention Module 202 Data Handling. This module will briefly introduce infection prevention and control data practices and kind of talk through some of the things as infection preventionists we do to handle missing data and then present data. Feel free to post questions through the presentation in the chat box. At the end of the presentation, we will have a learning activity to gauge your knowledge on the material presented. After we complete the learning activity, we'll go through the question and answers with the group. We will then open it up to questions from the audience. And during the learning activity, we'll ask that you can raise your hand and we will unmute you to give feedback and kind of talk about some of the questions. At the conclusion of the webinar today, when everything gets done, you'll be asked to take a post-survey evaluation of today's material presented. We would ask you to kindly complete this information so that it provides us with feedback so that we can better adjust the material presented to you, see what's working and not. This lecture has also been approved for continuing education for those who hold their certification in public health or their CPH. And at the end of the module, there is a last slide that shows you through the processes that you will need to complete to obtain your 1 hour of continuing education. And then within a week from today's lecture, you will receive an email with a copy of the slide deck and then also a link to the video presentation today. So just to recap, we'll have a learning activity, then we'll open it up for questions and answers. This module has been approved for 1 hour of continuing education for those who hold their CPH or Certified Public Health, and there's instructions at the end that show you how to go through that CE process. And then lastly, within a week, you will receive a copy of the slide deck emailed to you along with the link of today's presentation. So before we get into today's topic, we want to briefly introduce what TEPI is. TEPI, or the Texas Epidemic Public Health Institution, is headquartered here at UT's School of Public Health here in Houston with the goals of to keep the Texans safe and the Texas economy strong by preparing for the next infectious disease outbreak. As we're going through our presentation, you will see some QR codes at the end of the module that will give you links to other TEPI resources if you want to know more about the TEPI organization and different cores that we have to offer. My name is Kayla Rush and I am your presenter today. I am an infection preventionist who is certified in public health, healthcare accreditation practice, and infection prevention and control. During the pandemic, I had the opportunity to work in acute care hospitals here in Texas, and then I worked in a long-term care facility and nursing homes in New York City. And then I went out to California and returned back into acute care hospitals there before I returned to UT to pursue my PhD in epidemiology, which has a concentration in infection prevention and control practices. So today's learning objectives is to describe and explain what data infection preventionists collect, describe and explain how, as an infection prevention, we handle missingness and come up with ways to help clean our data. And then lastly, we'll briefly talk about data presentation. So before we get into today's lecture, we want to just briefly introduce some terminology. First is informatics, which is the study of information processing with the purpose of translating knowledge into practice. And then specifically for infection prevention, we really look at healthcare informatics, which is designing, developing, applying, managing, organizing, analyzing, and optimizing our data that we collect to help deliver to our healthcare personnel and counterparts with the goal to improve patient care and processes, along with creating a safer environment for healthcare workers and staff. And as with anything, when it comes to data, we want to make sure that we are using really good policies and procedure and that we're maintaining confidentiality and maintaining our HIPAA guidelines and standards. So before we talk about data, we first need to talk about HIPAA. As in healthcare, we have a lot of HIPAA regulations and guidelines. And when you're abstracting, learning, obtaining, doing different models, it is really important to make sure that you are being compliant within your organization and also within the HIPAA guidelines, laws, and recommendation. So the first big thing is always data security. A lot of things that we do as an infection preventionist, we obtain and ask a lot of sensitive, confidential data and protected health information questions. So we want to make sure that when we are obtaining this data, we are keeping it in secure ways and we're maintaining the privacy of our personnel. As we've talked about in previous lectures, some of our data that we obtain, we are required to have notifications to local and state health departments, and that was covered in our 100 series about our state-specific notifiable conditions. So that's also under the lines of HIPAA. That has been a requirement that we need to disclose this, but we also need to make sure that we are maintaining the individual's privacy and that we are only disclosing what the minimum amount of protected health information that is required. That also goes into some things that we do in the hospital, such as when patients are on isolation recommendations. You want to make sure that you are talking with your patient about disclosing to family members or visitors that are coming to them of what kind of data can you be sharing with them, and then maintaining their integrity and their privacy during that. If they're having visitors come in and they are on a certain type of isolation, they need to know what PPE to wear, but you also need to balancing what the patient wants you to disclose and what you need to disclose, and having those conversations before, not just disclosing private health information. Always when you're working with products and you're looking at data formulation and tracking and trending things along with disclosing or creating models for certain pathogens, you want to make sure that you're being compliant within the HIPAA regulations along with your specific facilities, policies, and procedures. So making sure that you are accessing charts that only you have for cause to be accessing, and that you are maintaining your credibility and you're within your scope of practice within your facility. Making sure that you're also having these expectations and practices with your business associates, aka your other staff members. For example, if there is a health staff related incident, such as when we talked about in 202, a bloodborne pathogen exposure, that maybe one of our staff members had a needle stick and we're working with occupational health to do a certain type of contact trace or get more information. That information is private and we don't want to be sharing that information with our other staff member, even though they might come to you and say, hey, I heard so-and-so got hurt. Can you tell me more about that? You need to make sure that you're maintaining their HIPAA regulations and compliance of saying that is private information, and you're only disclosing that information to those parties directly involved. If you are collecting certain types of data, making sure that if you need to add additional consent to some of your data abstraction, that you are asking the patient, and then also working with risk in your legal departments too, when you're collecting certain data. And then goes under your security that all your records are being maintained in a secure location. If that means encrypting files, locking Excel spreadsheets, having encrypted emails, locking binders under lock and key in offices. Those are also things to be mindful as well. And then if you're doing any type of research with this data, that you are following your IRB guidelines and only obtaining the data that you need to, and all of that is clearly written out in your protocol. So now that we've kind of gone through the HIPAA guidelines with data, what exactly is data? So data is a lot of things. It is facts, it's information, it's statistical values, such in infection prevention, we look at counts and rates. And specifically, we look at lots of metrics that we've talked about under our surveillance module, under our EPI module, and then all of our 101 modules that we did last year. We collect a lot of data. We look at hand hygiene, isolation compliance, high-level disinfection audits and monitoring, sterile processing. We do healthcare-acquired infections, exposure events, outbreak events, and anything else. So we collect a lot of data specifically on different events during different times. And after we analyze it, we calculate and predict and produce trends that are showing how our performance is, or if there's been a potential issue such as exposure events and outbreak events, if the increased number of events have then led to a cluster or a specific outbreak response. So we use a lot of data in practice. So now that we've talked about what data we collect very broadly, where do we get this data? Where are some sources that we can obtain all this information that we're collecting, monitoring, and tracking trend? And the four main components that infection prevention look at to obtain their data is our laboratory information systems, our pharmacy partners, our electronic health records, our EMRs, and then lastly, admission, transfer, and discharge notes from other facilities. And we'll talk about all of these components in detail next. So the first big data source that we get is using our laboratory information systems. And these information systems is directly linked to our laboratory and produces all of our results. So you can work with the laboratory and your bioinformatics or your IT team to really create specific reports for you that can be sent to you via fax or encrypted email to really help streamline your IT workflow, specifically looking at different reports such as your culture reports, your pathology reports, your virology reports, and then your emerging pathogens or other special reports. If you're having a special report done, maybe it's due to an outbreak event and there's a certain isolate that you are seeing that you are doing environmental testing for, you're doing additional screening for, there might have been an outbreak of a specific pathogen within the community, so then you're doing additional testing for. Some current emerging pathogens that we're seeing right now here in Texas are H5N1, Candida auris has been a common emerging pathogen over the last few years that we are now starting to really see in our healthcare populations here in Texas and across the country, along with Mpox a couple years ago. Some of our standard culture reports that we look at is our C. diff, our MRSA, our ESBL, any type of MDR-ROs that you are specifically looking at that you can talk with your lab team to see if there's certain trending of MDR-RO isolates that they're seeing in our patient population, or collaborating with pharmacy as well for their treating. For pathology reports, we always want our MTB to make sure if we have active TB or latent TB, and looking at the different testing mechanisms, if we're doing sputums, if we're doing our gram stains, if we're doing a PCR, if we're looking at cultures. And then also if we're ruling out anything of benign malignancy or infectious, different pathology as well, looking at those, seeing if there's any types of granulomas or if there is more of a cancer route. And those are things that you can collaborate with your lab department or pathology to specifically to ask about what are we seeing in our patient population, and then from that information, take it to your informatics or IT or EMR builder and see if that you can set up a specific algorithm to get the results streamlined to you. Virology, as we've seen in the past, COVID-19, our influenza A and B, and our RSV or any other type of seasonal flu or other different strains that you're specifically looking at, you can specifically have a virology report base. And from that information, you can decide if you want all test results, if you just want positive test results, if you want them sent daily, if you want them sent in batches. There's multiple different ways that you can formulate these reports. You just need to ask and sit down with your laboratory team and also your IT EMR or bioinformatics team to see how you can build these to really help streamline your workflow. So the next source of data that we look at is pharmacy records. And pictured here is a picture of a facility's angiobiogram. And angiograms are usually performed annually through pharmacy and lab, and they're looking at least 30 specific isolates and then looking at the susceptibility of different antibiotics. Every facility is different, and this information is based on the specific pathogens that are seen within your patient population and within your community. So every antibiogram looks different, it's a little bit created different, and the best way to understand this is specifically request some time, whoever does your pharmacy and prescribing records, to look at and really understand what you're seeing within your facility, so that you can use this information to help really advocate for good antibiotic stewardship. Use this information also to build into your annual infection prevention risk plan, and look at different surveillance measures too. If you're seeing a new type of MDRO within your community, that is something really great to pay attention to, that maybe you need to modify or update or advance your infection prevention practices based on what's kind of going on. You can also ask pharmacy to see if there's any types of trends that from 2 years ago to last year to this year, has there been a big shift in any susceptibility change for any specific isolate? That could be really great information to look at it, not only annually, but trended over time, to really see if there is potentially an emerging of an MDRO, which is usually signified of previously years, a specific species, such as, let's say, we had MSSA, which is methicillin sensitive Staph aureus, and now we're going to MRSA. Now it's methicillin resistant Staph aureus. So you can kind of see how things are trending within your specific patient population to identify areas of improvement, or to confirm that your practices are going well, that we're using good antibiotic stewardship, we're not having a big shift in our resistance within our specific patient population. Again, this is very complicated, and it's usually a huge, long output. This is just a small screenshot, and the best way to do this is to really just work with your pharmacy team and ask for some time to specifically look at this in detail and ask all your questions before you go into your stewardship committee meeting, so that you have clear ideas of what is being said and planned for the year. Next, then we have our prescribing hierarchies and reports. This is really good information to see and kind of understand to help advance your antibiotic stewardship compliance, and really being a good advocate for prescribing appropriate antibiotics when needed. And your hierarchy reports will probably be based on your antibiogram that we just saw, but that's again asking and working with your pharmacy collaborators. This is also great information to really look at and understand, because it allows you to identify opportunities from switching to IV to PO. If there's opportunities to downgrade a patient due to the specific organism and route of administration, and anytime that we can switch from IV to PO is great in HAI reduction, specifically in central line associated bloodstream or CLABSI reductions. Anytime there's an opportunity to remove a central line and go to oral, that definitely helps reduce our CLABSI risk. And then lastly, if that they can look at any specific risk factors for developing C. diff based on previous antibiotic usage. So if there are patients coming in that have used antibiotics, or that we have seen in our facility in the last 30, 60, 90 days, if they are being identified of, hey, this is a high-risk patient, maybe we need a second look of what exactly antibiotic that we're prescribing, making sure that we are using that we are not using broad spectrum antibiotics, but it was really narrow range as well, so that we are not having C. diff cases. And pharmacy is a great way to look at that and kind of work together as with the infection preventionist, the pharmacy, and then the attending provider, the lead provider on the case to make sure that we are all on the same page, that the patient has been identified at potentially developing C. diff and doing things to try to mitigate those risk factors. The next source of information that we get a lot of our data from are electronic medical records. This is our main source. We use our culture results, which, we can go into the individual patient's chart and look at it, along with what type of antibiotics they're on too, and along with other information. This is our best source of information that we use to really develop our case definitions. We use information obtained in their electronic medical records in the patient's chart if they meet NHSN definitions for any healthcare associated notes. Depending on your system, if you have the ability to put in specific notes, I highly recommend that you put in an IP note, because it's a great way to put all your information of where a patient has specific risk factors in infection prevention, if they are CLABSI risk, CAUTI risk, if they're a C. diff risk, if they're risk for MDROs, if there's surveillance, if they come from a risky or a high risk facility, such as a nursing home that has a case or a previously known case of Candida auris, and therefore we should put them on isolation and screen and make sure that we are obtaining those cultures that might take a while to grow and get results from. That's really a great place to have a centralized note to put all your information. So then later when the patient is discharged, other providers can look at that. And then if they're readmitting, you can see like, hey, they were at risk factors for XYZ. Let's put them on isolation. Let's order these cultures. Let's consult this person. It's really great information to do. Also, if your EMR system, if you use Epic and you're able to link to other facilities and see their encounters, that's a great way to kind of give a very great overview of the patient's care, and if this is an active condition versus a continuing infection. This was really helpful, especially during COVID, since that there's an incubation period, but people will shed dead virus and still test positive, but they're not infectious. Having this information can really help clarify if this person needs to be on isolation or not, or if they're high risk, or if we should be testing them. So it's a great way to see what type of risk that they have to other patients and staff members, but also a great way to make sure that we are using resources effectively and we're not putting people on isolation for past issues that are no longer infectious and they're not incubating, but they still might be shedding dead virus, but they're no longer contagious. So it's a great source of information, and we should be getting a lot of our overall data that we collect and trend through on specific patients through our source of EMRs. The last big source of data that we use is our admission, transfer, and discharge report. So anytime a patient is coming from another facility, such as if they're in a long-term care or they're coming from a nursing home they should have an admission transfer report, or if we're doing acute care to acute care, but maybe a different level of acuity that the facility has or a different service line, there should be a specific admin transfer report that also should be in the chart and then also verbally given when you're accepting the patient. This can be good and bad information, so you always want to use the method of trust but verify. And it can be very broad information. Say if you're getting information from admission, specifically from your EMS provider, saying that they picked the patient up from a nursing home. It was reported to them that the patient has a history of an MDRO, but they didn't say what source. They didn't say if it was in the blood, or if it was in the urine, or if it was in the sputum. You're not quite sure. So you're just getting this broad information that there is a history of an MDRO. And then your next question is, well, is this an active, or did they just have an MDRO long ago, but they were cleared? So you always want to use that trust but verify information. And then based on the information provided to you from either your EMS providers, your transfer team, or the facility that the patient is coming into, you can decide what room placement, isolation status, and surveillance screening cultures need to be obtained. For the example that I was saying, that a patient comes in from a nursing home with history of MDRO, but does not say site or source or date on MDRO, with this information, you can initially place them in a single room with contact isolation and then order specific cultures and maybe to look at, is it possibly in the urine or the blood or what exactly that you can do while you're kind of gaining more information and that you're identifying and kind of solving this missingness. It's broad information. They have an MDRO, but they don't say if it's active or past, and we don't know the source. But we're at least able from this information be able to decide like, hey, they need a single room placement because this is reported to us. We should put them on isolation status until more information can be gained, and then let's order some cultures right away so that we can get some answers to our questions. So that goes into now data cleaning. Now we've talked about what data that we track and trend, where we get it, what happens if all the data is not just there, which I just said it in my previous example, that you're getting information, it's not all there. There is missingness, is what we call it in epidemiology, which is very common in lots of different components. But the thing is, what do we do with this missingness and how can it affect? So this missingness can affect your analysis if you are doing specific modeling on infection prevention components and practices, and it can also affect how you are treating this patient and potentially putting other patients and staff at risk based that you don't have all the information that you need. If you're doing certain types of analysis or providing certain level of care with this missing information, it can bias your results or lead to issues by knowing like, hey, they're on, for the example that I gave before, they have an MDRO, but we don't know what it is. We're thinking like, oh, we need X level of precautions and they have to be by themselves, and we need to make sure that all visitors that are coming into that patient's room are adhering to PPE regulations and we're donning and doffing appropriately. But we don't necessarily know if that's accurate or not, since we're just saying there's a history of MDRO, it's not a current infection, maybe this infection is recalled and that site is now clean. So some of the causes that create from missingness is that this information is omitted, which we see a lot of times in infection prevention. It's just left out, or it's due to loss of follow-up, maybe that one care team was looking at something and then another care, they switched service lines. So another care team then was the primary on it and they didn't follow up on cultures, or the next step was to order a culture. They decided to discontinue the culture, but there's notes saying that this was potentially under the diagnosis and should be looked at and evaluated. Sometimes when you're asking patients about their history, sometimes they will refuse to tell you certain things due to fear or stigma, or maybe their orientation or their cognitive level when they're admitted as well for it. And if you're working here in Texas, also sometimes this information is omitted or refused due to fear that, maybe they're worried about their immigration status, that legal ramifications will be said if they say that, like, oh, they have a history of TB, that they might not be accepted or turned away. That can also what can cause people not to disclose information that causes then missingness in our data, which then causes failure to imply and implement infection prevention and control practices. So what can we do when we have missingness? There's two approaches that we can take to this. We can mathematically analyze our non-missingness, which is dropping our variable, or we can analyze our missingness in three different ways, looking at missingness, which is completely at random, which is the best type of missingness because that means that it's an systematic missing. So it has a cause, It has been created from error, or just random chance. There is not 100% completion. Sometimes there's missingness at random, which is a little concerning that maybe it's related to how we ask the question or a certain other tie to a variable, and then missing not at random will cause complete bias, is that there's a specific reason why this information is missing, such as a patient refusing to disclose XYZ due to fear that they might be deported or that immigration might get involved based on their status. And we'll talk more about this in detail. So how do we clean? We'll first talk about data cleaning statistically, and then we'll talk about how we handle it in our realm professionally. So if you are doing infection prevention data analysis and you're doing more mathematical models and looking at prediction models, doing conditional regressions, there's a couple different ways that we can handle our missingness. First is to drop your variable that you're looking at. So then you just have a complete case analysis, which means that all the data, it has been complete, that you're including it, and it's 100% data complete. You can keep your missingness and do an available case analysis of what the data is available that shows that you've been able to collect. You can mathematically assign a data indicator. You can, and then do some other simple imputations, such as conditional, simple mean, multiple imputation, and a likelihood basis imputation. And those are kind of how we mathematically, more on the epi side, to look at data, how we handle missingness. So we talk about mathematically, but what do we do actually in the hospital when we have missingness? We have data, as in we need to gather more information. What can we do and how can we obtain this in an appropriate, most efficient, timely way? The first thing is that you could do to try to clean your data or fill in your gaps of data is to interview the patient based on their age and cognitive consent. If they're, make sure that you're paying attention to how oriented they are. Ask the staff if the patient is available to speak to you, to try to obtain more data, especially as we go back to that example of a individual coming in from a nursing home, history of MDRO. Once they get settled, asking the patient, asking the nurse who has situated the patient, hey, is the patient oriented? Do you believe that they are accurately recalling their information? Can I speak to the patient of saying, hey, Miss Smith, my name is Kayla, I'm in the infection preventionist. I need to ask you a few more questions about some of your medical history. Is it okay to talk to you? Yes or no? And then asking them of, oh, I was looking at your medical records. We were told from your facility that you have a history of MDRO. Can you expand on that? And they might be able to say, yes, I had a UTI 2 months ago. I took my antibiotics. I had another culture. It came back negative and everything was fine. The likelihood of your patient being able to articulately provide that information is low. So therefore, then maybe going to a family member and asking them, or whoever is in charge of their primary care, their medical power of attorney, they might know that information as well. And with both of these types of approaches, making sure that it's okay to approach them, to discuss these things, you're in a safe space, that you're maintaining HIPAA regulations, and that you're talking to them in a private area to obtain this information. And then also, when you get information from a third party, making sure that you trust this information, but you need to verify it, just like with anything that they are reporting to us, saying, okay, great, well, they said that they had a UTI 2 months ago. You can contact the facility, which is our point 3. Then I'm saying, hey, Miss Smith was transferred into our facility. It was reported that they have an MDRO. Talking with the patient and the patient family, they reported that they had a UTI 2 months ago. Can I get a copy of that? Can you fax that to us? Or do I need to request in our EMR system that I have access to that patient record? Or can you just quickly verify that within your charts too? So that you know what cultures to put or if they need to be on isolation or not. So then with the information obtained from the patient and the family member, then verifying it with the previous healthcare facility, either from your transfer documentation and information that EMS provided to you, and then following up with admitting and transferring or discharge notes from the facility that you were receiving the patient. So if they are coming from a nursing home, calling that specific nursing home saying, hey, I'm the infection preventionist. We have Miss Smith here. She was admitted, blah, blah, blah. I have a question about her history of an MDRO. Do you have access to XYZ? So that can kind of help you streamline of getting those results and then making sure that your infection prevention control practices are aligned with what you need to do. And then lastly, if they don't have records of that, maybe your local health department does. We specifically saw this in some areas with COVID of knowing their COVID-19 test result, that they would have certain copies of it, and you can partner with your local health department to get copies and kind of share data of saying, do they need to be on isolation? Do they not? So really reaching into those other avenues to help making sure that you're cleaning your data, i.e. all information obtained is true and accurate, and you have a complete picture of your patient's health so you know what infection prevention control practices to implement. So now that we've talked about the data we collect, where to collect it, how to clean or identify gaps in our data, let's talk about our last component of how do we then present this data. And some 5 main questions when you talk about data presenting is, who is my audience? So who am I presenting this infection prevention data to? What am I trying to say? What questions do I think they might have? What answers am I finding for them? And then what other questions could spark or be inspired by my presentation? So the first thing with data visualization, it is a great way to graphically represent our information and our data. It's able to visually help our audience see and understand trends, pattern, identify the distribution, see the spread of data, and also see outliers. It's a great way to use a mix of charts, graphs, and tables, depending on what type of data you have, and then also what is your message of your data. And you can use these tools to help identify areas of improvement, along with demonstrate your impact. Showing a low compliance rate in a certain metric will have a different visual impact compared to just putting words on paper with it. It can also help you better understand your sample population, aka what service line or specific pathogen that you're seeing, kind of figure out what's going along. And this will also then help you identify other clinical collaborators that you might need to tap on your shoulder to help with, or that maybe when you're tracking their data or looking at it, maybe that they can help you or you can help them, and identifying what the needs are based on how this data is presented. And then lastly, it will give great justification for resources that you need or problem areas, along with also showing areas that are doing a great job, that are really compliant with their infection prevention practices. So some pros, like anything, there's always pros and cons or advantages and disadvantages with certain presentations. For data visualization, it's a very efficient way of sharing information. You can visually explore different opportunities, directions, collaborators, need, resources, and you can also see the data patterns and relationships. However, there's also some disadvantages. Depending on your data and your data set, if there's missingness, not missingness, that can also create bias, as we've talked about. If there's a lot of missingness, and depending on the type of missingness, that can lead to a lot of bias and inaccurate information that is being then visually shared in your data. As we say in epi and in science, correlation does not necessarily mean causation. So that is always a clear distinction that you need to make when you are visually presenting data of just because the data says this, it doesn't necessarily mean this. And then lastly, the core message can get lost in translation due to the complexity of your data that you're visualizing, not being clear, your data being not great. There's the other things that can happen. And this is also a very important skill to have. It really helps your audience and your key stakeholders see, collaborate, and connect with the topic better because they're able to see the trends and kind of just visually understand what is going on. And by increasing and improving their understanding, that's going to lead to more support to fix the problem, which is all of our goals, is to better support and fix problems to produce better care for our patients and create safer working environments for our healthcare partners. And lastly, with presentation of data, you always want to look at what results are worth presenting. Just because something's important and neat to you, it doesn't necessarily need to be presented, even though that we've done different modelings, we've taken different approaches, we think things are cool. That doesn't necessarily mean our audience will also have the same appreciation. So always making sure that you're looking at the most appropriate format for the information and who you're presenting it to. So look at what type of data you have, what are you trying to say with it, who's going to be your audience, and what impact or what type of results are you wanting to stem from your data presentation. The goals are always to keep it simple. Your tables and graphs should be able to stand alone without detailed explanation. You don't want to misrepresent the data. But also good tables and graphs, you can have beautiful tables and graphs and models, but if your data is bad, that will not be a good thing. And then you always want to make sure that your visuals are enhancing your message, making it more clear, concise, and that it's not making it more convoluted or confusing. So here's just some examples of some visualization, which you see that we have it in table form, and we'll kind of show you different styles of some data visualization that you can use. So the first example, we have hand hygiene compliance rate through the year. So here's just a specific table that gives our 12 months and then our compliance rate of hand hygiene. Not a lot of information that to go on for it. Tables are great basing on what you kind of wanting to present. It goes back to what are you presenting, who's your audience, and what kind of impact. And, you know, determining if you should use a table or a graph to really enhance your message. You know, this kind of table is not really adding enhancement to what you're trying to say, that the compliance rate in some months were better than others, and there were some opportunities for improvement in other months. Compared to, then we go into a different type of visualization graph. So now we're going into, that's our same data, now in a line graph showing our compliance rate throughout the year. So same information, but however, this one kind of really shows more visually, oh, we were doing okay at the beginning of the year. We had we started at 88 and we had our peak at 93, and then we had a drastic dip over the summer, which is not great because during that time of April to May, that's when our seasonal flu goes our way, usually. But then we're having more, you know, it's summer, there's more foodborne pathogens due to having picnics and other things, so we should be really washing our hands. And foodborne pathogen outbreaks leads to nausea, diarrhea, fever. So then we have an increased risk of transmission when we have a decreased risk of hand hygiene. Also during this time, sometimes we have our new providers coming into our facility over the summer months, so that might be a certain indicator of, hey, we need to better orient our new staff that's coming in to our facility. And then we're seeing, oh, in August, towards Christmas and more towards flu season, we started to pick back up. So the data kind of shows two different things. So next we have the same data, but now in a bar graph too, and it's kind of the same visually presentation that we saw in our last graph. So a line graph and a bar graph kind of really show the same different thing, and it's showing the different trends. And you can kind of see here, we have an upward trend, and then we have our downward during the summer, and then peaks back up again. So then this is the same data, again, now in a pie chart, which is not, it doesn't accurately show us what's going on in the facility. This would be an example of not picking the right visualization to go with your message. So using a table as we saw, and then now using a pie chart to look at the different levels of compliance throughout the year really does not accurately show that, like, hey, if you're just looking at this graphically, you're seeing, oh, complete compliance, it's a circle, we don't have any missingness. But then when you're looking at it, well, each slice kind of looks like the same level, but the same level of compliance was different in the month. So this is where now where our visualization tool is not adequately representing our data, it's not enhancing it, and it's potentially getting lost in translation of what we're trying to say, what our data is saying versus what our graph is showing. So next we have our geospatial visualization, which also is specifically that you might not necessarily use in the hospital setting, but if you want to do different infection prevention models. But this is using more geospatial, as in like different country or unit or region specific data to kind of show the impact of certain results. So here that we see from the WHO and UNICEF monitoring water supply throughout the world and having access to hand hygiene. So as we know, different income countries, and then you go to the right picture, upper, lower income, and worldwide countries have different levels and compliance with basic soap and water due to having access to clean water compared to other countries as well. So this is just another way to look at your data. We usually don't do this in infection prevention. You could do it like geo mapping your facility to trace different outbreaks. But you can also show that in your outbreak contact trace response too. Next, we have our infographic visualization, which is a mixture of words and numbers to really show your impact. Just a reminder, World Hand Hygiene Day is May 5th. So that's internationally wash your hands. So coming up this week, please, on May 5th, when you are doing compliance with soap and water for at least 30 seconds, or happy birthday, that you are remembering it's World Hand Hygiene Day. And this is just another way to kind of show and enhanced and get a different type of impact of words and graphics together to really show the importance of the message. And then lastly, this is just an example of a dashboard. As we talked earlier, based on your EMR system and working with your EMR builder, your informatics or IT person, they can build you infection prevention dashboards based on certain tools. In Epic, there's an infection prevention dashboard. If you use Tableau, that's another thing. You can use in some other facilities using Theradoc. There's all different types of metrics that you can look at and build, and it's a great way to communicate your message, especially in your committee meetings, to really see what the levels that you are at and kind of putting a plan in place of how to really, move that metric from 50% to 75 to 100%. So to wrap this up, we've really talked a lot about infection prevention data today, and it's a really great tool to communicate information to multiple audiences. It's great when you can have a hand hygiene tool or graph, as I saw that line graph or bar graph. You could show that to your C-suite, you could show that to your environmental and environmental service industries, you can show that to your providers, and it's all communicating the same message, which is great. And you can, but you can also modify it to change your message based on your audience too, of how you're wanting to communicate this information, which you're going to have a different presentation and different messaging style, as we've talked about in previous lectures, based on your audience. Specifically, how you talk to your C-suite is going to be different than your frontline workers, to your administration, and you can modify your visuals as needed. And the most important is choosing the correct visual message will really help get stakeholder buy-in, which then will lead to more support, more resources to really identify and improve the issue. So now it's your turn. So we're going to ask you now to scan the QR code to do the knowledge check. It's a quick 10-minute questions with multiple choice. The QR code is on your screen, and then we will go through the answers at the end of the session. So question 1. Blank is the science of using information to design, develop, apply, manage, organize healthcare delivery. Is it A? Is it B? Is it C? Or D? And feel free to put your answers in the chat too. Or raise your hand and we can unmute you as well. Here's the QR code again. Great. All right. So to design, develop, apply, manage. Is it informatics, healthcare informatics, data handling, or information handling? It is B, healthcare informatics. Informatics is kind of general, but specifically the keywords of healthcare delivery, therefore it's healthcare informatics. Question 2, what does HIPAA mean? Is it our Healthcare Insurance Probability and Accountability Act? Is it our Health Information Portability and Accountability? Yes, B. 3, what of the following sources? So where do IPs get their sources of data? Do we do pharmacy, electronic health, admission transfer? Yes, awesome. D, great job. 4, what are effects of missing data? Great, yes. B, missing data can generate biases and also lead to issues of not having the right infection prevention regulations, recommendations being implemented. 5, what approaches ensure information for patient interview to be correct and reliable? So do we want to just believe their word of mouth? Do we want to trust but verify their information that providing to us? Do we want to validate everything? Or D, all the above? So the answer is A, we want to trust and verify approach. So we never just want to believe, the word of mouth approach is appropriate, but you need to go and trust and verify the information. That's the best answer to the question. C, what kind of data visualization is this? Awesome, yes, it's geospatial, and it's a lovely picture of Texas. Question 7. What is the visualization that we use a mixture of visuals and words? Yes, A, infographic. 8. Which of these factors determine the method of data presented? The type of data, our audience, our message, or D, all the above? Yes. D, all the above. It's all great things that we need to take into consideration when we are creating our data tools and our presentation. 9, which of these are protected health information? Discharge date, phone number, insurance information, D, all the above. Yes, D, all the above. All of this is PHI that we need to make sure that we are within our HIPAA regulations and that we're maintaining confidentially and keeping it private. And our last question, during the data cleaning process, it is uncommon to see missing data. B, yes, it is false. Usually we see missing data very commonly, and then we've provided you with tools to kind of handle them mathematically, along with what you can do in the facility, where to go to obtain more information so that you can implement good infection prevention practices. So here's the answers. And then as I mentioned at the beginning of the lecture, you will receive a copy of this slide deck with the answers. So if you want to take the quiz over later, you sure can. So before we want to open it up for questions, we'll just, here is our email that you can specifically email us any specific questions that you have on the material, anything that we can help you with. Here's a couple QR codes. The bottom right is our TEPI QR code that will take you to our TEPI site that you can look at other cores that the Texas Epidemic Public Health Institution has and different initiatives that they're doing. Here's the QR code to our IPC series that we are conducting with additional upcoming webinars that we're holding. And then our general information queries that you can send to this email and then connect with us on our social media platform. So lastly, our next module will be IPC Module 205, and we're covering hemodialysis. And we're going to do kind of an overview of hemodialysis, the specific CLABSI or central line associated bloodstream risks that hemodialysis pose, and then how we monitor and audit hemodialysis. And then lastly, we would like you to complete the evaluation survey, which the QR code is on the screen. This is great information for you guys to complete because it helps us really develop the modules and kind of give feedback of how we are presenting, if things aren't clear, additional topics that we can present to you all. For those that complete the post-survey evaluation, you have your opportunity to provide your email and a winner will be drawn and some TEPI swag will be emailed out to you. And yes, I just saw the question for the CE. So here is the process to obtain your CPH, your Certified Public Health, or if you have that credentialing, continuing education instruction. So you can click on the link provided or scan the QR code. Again, these slides will be provided to you within a week. So you'll have a copy of it that you can copy and paste this into. It will first ask you to create and register a Learning Stream account. And then you will go register for the infection prevention course that we went over today. And then after you register, you'll provide an email during your registration. And to that email that you provided, and another email will be sent with the learning check that we went over today. It'll ask you to complete it, and then it will send you another email with a post-survey evaluation. And then after you complete that, a third email will be sent to you with your 1-hour certificate CE credit for that. So again, this information is included in the slide deck that will be emailed to you within a week. So now we'll kind of open it up for any questions that the group has, and we thank you so much for attending today's module. Any questions from the audience? Okay. Well, if there's no questions, we're happy to conclude today's webinar. We thank you all for taking your time out of your day to listen to us. And we hope to see you in the next webinar in June. Thank you so much.